Let's continue our discussion on chromosomal abnormalities, this time focusing on the sex chromosome abnormality, Turner syndrome. For this sketch, we'll be venturing out to the local mini-golf course, Putter Junction, where a crowd of children is gathered around the notorious turning windmill, which you know is always the hardest putt. Turner syndrome is characterized by a variable phenotype, but the most common findings include short stature, a short, webbed neck, a shield chest, left-sided cardiac disease, and minor skeletal anomalies. It is the most common sex chromosome abnormality found in females. This is represented by the number 1 foam finger held by the cheering girl with the X chromosome barrette. So, what causes Turner syndrome? About half of the time, Turner syndrome is caused by monosomy X, which means that a female has only one X chromosome rather than the anticipated 2, hence the single X-shaped turning windmill blade. These patients with monosomy X Turner syndrome tend to have the most severe phenotype. In contrast to the trisomies, monosomy X is most often caused by paternal meiotic non-disjunction rather than maternal, which is why the course is called Putter Junction for paternal non-disjunction. Alternatively, some girls with Turner syndrome are mosaic, meaning they have some cell populations with the anticipated 46XX karyotype, while other cell lines have the 45X karyotype. Note the mosaic flower pot holding the bush with X-shaped flowers. Patients with mosaic Turner syndrome generally have a less severe phenotype, which is not the case with patients with mosaic trisomies. Sometimes, mosaic Turner's patients can even have mosaicism involving the Y chromosome, meaning that they have some cell populations with 45X karyotype and others with 46XY. Often, there are just portions or remnants of the Y chromosome left behind. Note the other mosaic flower pot containing the bush with Y-shaped flowers. Overall, about 10% of patients with Turner syndrome have some amount of residual Y chromosome material present on chromosomal studies. Structural changes on one of the X chromosomes can also cause Turner syndrome. These patients have 2 copies of the X chromosome, but there are significant enough changes on one of the X chromosomes to lead to the Turner syndrome phenotype. Examples of these structural changes include ring X chromosomes, deletions, and more. Note the broken X-blade on the windmill far off in the distance, in the older, most definitely haunted area of the park. Turner syndrome is seen in about 1 in 2,000 live births. However, it's been estimated that only about 1% of all Turner syndrome-affected fetuses survive to term. The other 99% result in miscarriage. This miscarriage rate is depicted by the knocked-over baby carriage. So, how do Turner's patients generally present? Sometimes the diagnosis is made prenatally. There are a number of prenatal ultrasound findings that can raise suspicion for Turner syndrome. These are represented by the recurring sketchy symbol of the pregnant woman holding an ultrasound bullhorn. Some of the prenatal ultrasound findings in Turner syndrome include increased nuchal translucency on first trimester ultrasound, represented by the thickened scarf at the back of this girl's neck, IUGR, depicted by the restricted sign in the water hazard over here, cystic hygroma, which is a fluid-filled sac generally caused by lymphatic buildup, often in the head or neck area, shown here by the rounded putter over the girl's shoulder, fetal hydrops, represented by the floating baby doll in the water hazard, and left-sided cardiac anomalies, including coarctation of the aorta and bicuspid aortic valve. Renal abnormalities, note the kidney-shaped water hazard, and shortened humerus or femur may also be present. Alternatively, you may be concerned a fetus has Turner syndrome based on results from a NIPT or NIPS test, which is a serum test on the mom looking for cell-free DNA from the fetus commonly done in women of advanced maternal age, defined as aged 35 and over. NIPT, NIPS testing can be quite predictive for trisomies, but is less reliable for the sex chromosome abnormalities, so further diagnostic testing should be entertained. If the prenatal ultrasound or NIPT/NIPS testing leads to concern for Turner syndrome, then some patients might elect to proceed with formal prenatal diagnostic testing to definitively rule in or rule out the diagnosis of Turner syndrome. Options include first trimester chorionic villus sampling, represented by the corn dog samples on the food cart, or second trimester amniocentesis testing, represented by the amnio apple juice samples also on the cart. In either case, the sample obtained can be sent for a karyotype analysis to determine whether the fetus has Turner syndrome. Karyotype testing is represented here by the chromosome-shaped chorotypes display. Sometimes a prenatal diagnosis of Turner syndrome is made incidentally. For example, a mother might get CBS or amnio testing for another reason, and the final karyotype result diagnoses Turner syndrome in the fetus. However, many Turner's patients are not diagnosed prenatally. These patients generally present in one of two contexts. You may see concerning findings on a newborn physical exam that make you concerned for Turner syndrome. Or you may be treating a girl with short stature and/or amenorrhea, and you evaluate for Turner syndrome as part of the workup. Let's review some of the common signs and symptoms of Turner syndrome to understand a bit more about how these girls present. Remember, Turner syndrome occurs only in females. The most common sign of Turner syndrome in the newborn period is lymphedema, which shows up as non-pitting edema over the backs of the hands and feet. Lymphedema is represented by the puffy gloves and the chunky clogs on this Dutch girl cutout. This edema generally spontaneously improves with time, but may not fully resolve and should be monitored closely. Beyond lymphedema, there are a number of other physical exam findings that you may see in the newborn period that are concerning for Turner syndrome, including a webbed neck, represented by the webbed Dutch hat, low-set ears, represented by the low ear-like beads on this girl's braids, a high-arched palate, represented by the high-arched hat, micrognathia, or a small chin, depicted by the garden gnome covering his chin, nail dysplasia, depicted by the twisted nails falling from the windmill blade, and shortened fourth metacarpals or metatarsals, represented by the shortened fourth golf club here. Let's switch gears now and talk about the physical features of Turner syndrome that you may find in an older child. The most common and consistent finding in patients with Turner syndrome is short stature. Short stature is so common, in fact, that you should suspect Turner syndrome in any girl with short stature and a growth velocity less than 10th percentile for age who is tracking at substantially less than expected for her mid-parental height, especially if you see other physical exam features that may be consistent with Turner's. What features, you ask? Other features of Turner syndrome include a low posterior hairline, depicted by the low posterior neckline on the back of this Dutch girl cutout, broadly spaced and inverted nipples, which is frequently described as a shield chest, and cubitus valgus, seen here with the Dutch girl's arms bent outward at the elbows. If you see a newborn with lymphedema, or an older girl with short stature, especially if you see any of the other possible physical features of Turner syndrome, you may be heading towards a hole-in-one with your diagnosis if you send a karyotype to confirm your suspicion of Turner syndrome. Even if you have a prenatal diagnosis of Turner syndrome, you should still order a karyotype on the baby after birth to confirm the diagnosis. What if it's actually not Turner syndrome? What else can look like it? Noonan syndrome shares some similar features with Turner syndrome, though it occurs in both males and females. Check out the Sketchy DDX menu to learn more. Okay, so now that you've made the diagnosis of Turner syndrome, what do you tell the family and what workup needs to be completed? Since the Turner syndrome phenotype can be quite variable, and there are a lot of health implications to consider when you make this diagnosis, it's important to utilize a multidisciplinary care team consisting of medical specialists, genetic counselors, social workers, and more. Go team! Specific guidelines exist from the Turner Syndrome Foundation regarding delivering the diagnosis of Turner syndrome to the family, and there are clinical practice guidelines to help guide the complicated management. So, don't worry, you're not alone. Counseling for these families should start at the time of diagnosis, whether that be prenatally or after the child is born. During the course of these discussions, many families ask about their risk of having another child with Turner syndrome. The vast majority of Turner syndrome occurs sporadically, and it is not typically inherited. So the risk of having another child with Turner syndrome is not more than the general population risk. The diagnosis of Turner syndrome can often be overwhelming for families. Allow time for them to process and ask follow-up questions later. Providing families with resources for local and online support groups focused specifically on patients with Turner syndrome can often be very helpful. Once the diagnosis of Turner syndrome has been presented to the family, it's important to review the management plan for these girls. We'll review both the initial evaluation at the time of diagnosis as well as the more long-term follow-up plan. Let's start with the initial evaluation. A thorough cardiac workup is important for all Turner syndrome patients, which includes an echocardiogram depicted by the ultrasounding bullhorn pointed at the heart-shaped putter, an ECG represented by the girl's ECG grid skirt, and 4-extremity blood pressures depicted by the 4-extremity sweatbands. Up to half of all patients with Turner syndrome will have a congenital heart anomaly. The most common is a bicuspid aortic valve, seen in 15 to 30%, which is represented by the bicuspid doors in the windmill, or coarctation of the aorta, seen in 15%, which is depicted by the constricted arch over the windmill's doorway. Other aortic arch abnormalities are very common, with an elongated transverse aortic arch seen in up to 40 to 50% of patients with Turner syndrome. A variety of other cardiac abnormalities can be seen as well, including septal defects, systemic or pulmonic venous abnormalities, and coronary artery defects. A renal ultrasound, represented by the kid with the ultrasounding bullhorn holding the kidney-shaped putter, should be ordered on all kids with Turner syndrome at the time of diagnosis to evaluate for underlying collecting system anomalies, depicted by this ureter-shaped club handle, or horseshoe kidney. Renal vascular anomalies and other positional abnormalities are also common in these kids. In addition, thyroid screening with a TSH and free T4 should be done on all kids with Turner syndrome at the time of diagnosis, as these kids are at a higher risk for autoimmune hypothyroidism, as well as other autoimmune diseases. More on this later. See the T4 golfer with his antibody putter and his clownishly large thyroid bow tie? Now that we've reviewed the initial evaluation for girls with Turner syndrome, let's discuss the ongoing management and health complications to look out for in these kiddos. Remember we mentioned that short stature is the #1 symptom in girls with Turner syndrome? This short stature is due to growth retardation in infancy and childhood, as well as delayed puberty and the lack of a pubertal growth spurt. Patients with Turner syndrome should be tracked on syndrome-specific growth curves, hence the curved reads that kinda look like a growth chart. Treatment with growth hormone is indicated in most patients to help them achieve maximum height potential. Growth hormone supplementation can also help reduce metabolic complications of Turner syndrome. More on that in just a bit. Most patients with Turner syndrome have primary ovarian insufficiency, from primary hypogonadism or hypergonadotrophic hypogonadism, meaning elevated levels of LH and FSH and low estrogen. This is represented by the wilted, falling female flowers under the elevated flower-stimulating light. The degree of ovarian failure is variable in each patient. The primary ovarian insufficiency is due to the presence of ovarian dysgenesis or streak ovaries, which means the ovaries are largely made up of connective tissue rather than being filled with follicles. These streak gonads, depicted by the streaks in the dirt as this girl attempts to get her ball out of the thick rough, are formed due to increased oocyte loss, starting as a fetus, indicating that the presence of two X chromosomes must be necessary for some aspects of oocyte survival. Because of this gonadal failure, most girls with Turner syndrome have no breast development and primary amenorrhea, represented by the spotless white skirt and the X's over the breasts. Some patients, especially those with mosaic Turners, may have initial pubertal development followed by pubertal arrest. Fewer than 10% of patients have normal puberty and menstruation. Serial physical exams assessing for pubertal development are important, and measurement of FSH and anti-Mullerian hormone, AMH, can be done starting around 10 or 11 years of age to help evaluate pubertal progression. AMH levels may be the best indicator of pubertal follicle development for these kids. Estrogen supplementation, represented by the Estrogrow fertilizer, is generally started around 10 to 11 years of age, with progesterone supplementation, represented by the Protect fertilizer, added a few years later to help prevent endometrial hyperplasia. The estrogen dose starts low and gradually increases over several years to mimic normal pubertal progression. Estrogen supplementation has other long-term health benefits, including improved bone density and prevention of cardiac complications. We'll talk more about those soon. Girls with Turner syndrome who are mosaics with any amount of Y chromosome material present need additional malignancy prevention. These kids are at an increased risk of gonadoblastoma, so they should all undergo prophylactic oophorectomy or salpingo-oophorectomy to reduce this risk. So we've got a gardener snipping some gonadal flowers off the mosaic Y bush. Ouch! Kids with Turner syndrome are at increased risk for learning difficulties, though they generally have normal intelligence. Serial developmental and neuropsychiatric screens, represented by the Brain-Shaped Golf Club, are recommended throughout childhood to evaluate for these. Common problems in Turner syndrome include ADHD and issues with nonverbal problem-solving skills, especially math, visual spatial reasoning or organization, executive functioning, social cognition, and psychomotor skills. Another problem common in Turner syndrome patients is autoimmune diseases. Regular screening for autoimmune thyroiditis and hypothyroidism should occur starting around age 4 with annual TSH and free T4 measurements, and celiac screening should be done every 2 years starting at age 2 for all patients with Turner syndrome. This elusive mini-golf seal should remind you to check for celiac disease. Inflammatory bowel disease can also be seen in Turner syndrome patients, so keep an eye out for persistent abdominal pain and bloody stools. Regular audiology evaluations are also important. Kids with Turner syndrome often have recurrent otitis media due to abnormalities with the eustachian tubes and cranial base, which can lead to conductive hearing loss in childhood. Over time, Turner's patients are also at risk of developing sensory neural hearing loss as adults due to abnormal hair cells in the cochlea that worsen with age. Regular screening eye exams are also important in Turner syndrome patients, as they have an increased incidence of various eye conditions, including strabismus, depicted by the deviated eye golf balls, amblyopia, hyperopia, and myopia, represented by those Coke bottle eyeglasses, as well as other problems, such as ptosis and colorblindness. Let's focus for a minute on cardiac health for these patients. Cardiac disease is the most serious medical complication for patients with Turner syndrome. Even those without known cardiac disease are at a high risk for developing hypertension, shown by the angry high-pressure steam, and aortic root dilation and dissection, shown by the cracked and splitting golf club handle with the bulge where it attached to the heart. Other possible cardiac problems include progressive vasculopathy and coronary artery disease, long QT, and other conduction abnormalities as well. Even if the initial cardiac imaging tests are negative at diagnosis, all patients with Turner syndrome should have a repeat echocardiogram, or better yet, a cardiac MRI if they can tolerate it without anesthesia, at least every 5 years in childhood and every 10 years in adulthood, as well as routine blood pressure monitoring at every medical visit. So, what can these patients do to reduce their cardiovascular risk? Good blood pressure monitoring and maintenance is key, along with other standards of care for cardiac health like a healthy diet and exercise, smoking avoidance, and cholesterol management. Most Turner's patients are on long-term estrogen supplementation, which can actually help decrease their cardiovascular risk as well by improving their lipid profile and aortic stiffness. Close monitoring for central obesity, dyslipidemia, insulin resistance, and type 2 diabetes is important as well, since patients with Turner syndrome are at increased risk for these metabolic disorders, even if they aren't eating donuts and candy all day, like this girl. Annual blood sugar and lipid labs should be done starting at 10 years of age. Remember, too, that growth hormone supplementation can reduce central obesity and improve glucose tolerance. Skeletal problems are another area of concern for Turner syndrome patients. Scoliosis and kyphosis, represented by this curvy vertebral putter, are quite common, seen in 20% and 50% respectively. Spine x-rays, represented by the recurring sketchy skull and X-bones, should be done at 5 to 6 years of age and again at 12 to 14 years of age. Clinical scoliosis checks should be part of every routine exam in these patients, and are especially important during periods of growth hormone supplementation. Other skeletal problems include maid-lung deformity, also called a bayonet deformity of the wrist, represented by this shifted end of the putter, as well as genu valgus or verum of the knees. In addition to these skeletal abnormalities, Turner's patients have problems with poor bone mineral density and osteoporosis, likely due to intrinsic bony abnormalities. Note the cracked and degrading bone post on the deep rough sign. Supplementation with estrogen and growth hormone and optimizing vitamin D and calcium intake is important. 25-hydroxyvitamin D levels should be checked every 2 to 3 years, starting in late childhood, 9 to 11 years of age. Regular DEXA scans should be started in late adolescence or early adulthood. Alright, just a few more words on the transition to adult care. It can be a rough ride for some of these patients, so prepping a few years ahead of time is important. Help teens start to take accountability for their own care and plan ahead which adult medical specialists should be involved. Fertility may be a big concern in teens and young adults with Turner syndrome. This is depicted by the recurring sketchy infertility tree. Early referral to a reproductive endocrinologist during childhood is important to discuss the possibility of oocyte cryopreservation. Pregnancy is not advisable in Turner's patients due to increased complications such as aortic dissection. The overall mortality for Turner syndrome patients is increased 3-fold compared to the general population, mostly due to non-congenital cardiac problems like coronary artery disease and stroke. Mortality rates are higher for 45X patients than for mosaic Turner patients. All right, this is the end. We made it to hole 18. Let's review one more time before we take our last shot. Turner syndrome is the most common sex chromosome abnormality in females. It is characterized by a highly variable phenotype, which almost always includes short stature in addition to other physical features such as lymphedema, webbed neck, shield chest, left-sided cardiac disease, and low posterior hairline. Turner syndrome is generally caused by either monosomy X from a paternal meiotic non-disjunction event or from chromosomal mosaicism. It is less commonly caused by significant structural changes in one of the X chromosomes. Mosaic Turner syndrome patients generally have a less severe phenotype. The diagnosis of Turner syndrome is made based on karyotype testing. Prenatal diagnostic testing for Turner syndrome can be done via CVS or amniocentesis samples. This testing is generally done if concerns arise from an abnormal NIPT or NIPS screening test, or the prenatal ultrasound shows abnormal findings such as increased nuchal translucency, IUGR, cystic hygroma, fetal hydrops, cardiac and renal abnormalities, or a short femur or humerus. Postnatal diagnosis of Turner syndrome can be made in the newborn period or much later in childhood. The most common finding of Turner syndrome in the newborn period is lymphedema of the hands and feet. Other physical exam features may include a webbed neck, nail dysplasias, shortened fourth metatarsals or metacarpals, low-set ears, and micrognathia. The most common finding of Turner syndrome in an older child or teenager is short stature. Other physical features may be present, including a low-set posterior hairline, shield chest, and cubitus valgus. Initial management consists of cardiac screening with an echocardiogram, ECG, and 4 extremity blood pressures to evaluate for aortic valve disease and coarctation of the aorta. A renal ultrasound should also be done to evaluate for collecting system abnormalities, horseshoe kidney, and renal vascular anomalies. And initial thyroid testing with TSH and free T4 should be done on all patients. Ongoing management for Turner syndrome includes careful growth monitoring on Turner syndrome-specific growth charts, hormone supplementation with growth hormone, estrogen, and progesterone, neuropsychiatric evaluation for learning disabilities, regular thyroid and celiac testing, and routine ongoing hearing and eye screenings. Continued cardiac monitoring is essential, even in those without known congenital heart disease. All Turner syndrome patients are at high risk for hypertension and aortic dilation and dissection, as well as other cardiac diseases, such as coronary artery disease and conduction disorders. Estrogen supplementation can improve cardiac mortality by improving aortic stiffness. Routine screening for obesity, hyperlipidemia, and diabetes is important as well, as Turner syndrome patients are at higher risk for these metabolic complications. Estrogen and growth hormone supplementation can improve these outcomes. Poor bone mineral density and osteoporosis are common in Turner syndrome, so vitamin D and calcium optimization are important. Growth hormone and estrogen supplementation can also improve BMD. Other skeletal complications include kyphosis and scoliosis, as well as Madelung deformity of the forearm and genu valgus or varum of the knees. Most Turner's patients have primary ovarian failure due to streak gonads and are amenorrheic with no breast development, though some will have initial pubertal development followed by pubertal arrest. The overall mortality rate for Turner syndrome patients is 3-fold higher than the general population, typically from non-congenital cardiac disease such as coronary artery disease and stroke. Okay, deep breath. Gauge the wind. Cinderella story.
It's in the hole! It's in the hole!